All right. Right. So we'll talk about the pre-hospital and the acute management of burn patients. We'll talk about all the other kinds of things that we take care of besides burns and frostbite. And we'll have a case presentation at the end. The thing I like to point out, and all these are my pictures and pictures of patients I've taken care of, that this is a young lady who was involved in a meth lab explosion. And she has a pretty significant burn. I think she was 80%. But regardless of the size of burn, nowadays, these patients are not kept in a coma. They are awake, alert, interacting, walking, eating, talking. And we have found that by doing this, we have significantly decreased our morbidity and mortality rates, which we'll talk about it here in a minute. We saw this big group of people, same information as before. We take care of, by the way, patients that are 14 years of age and up. The Children's Hospital, which is kind of, they call it across the street, but it's a few blocks down the street, takes care of kids that are under the age of 14. That's where we're located. We already talked about all the people we take care of. So burns affect a lot of people. So you can see that, and this is a very conservative estimate because, as we know, especially from where we come from, we don't run to the doctor because we burned our finger or our hand. We stay home and we treat a lot of those things at home and only come in if it's a more significant burn. So it's probably very conservative. Of the ones that present to emergency departments, about 80% are minor and go home. About around 500,000 of those will seek treatment, and of the 500,000 that seek treatment, about 10% of those will actually end up getting admitted to the hospital. You can see the percentages of what we see. Those percentages change from an age standpoint, and we'll see that here in a minute. Kids, number one. Kids, we see a lot more scald and contact burns. So those are their most common cause of their burn injuries. They pull lots of hot liquids down on themselves. Even no matter how much we're trying to be careful, kids can find a way into getting just about anything they want to get. And they also have to touch everything. They have to feel their world. So we get a lot of contact burns from kids touching hot fireplaces, stoves, you name it. So as we can see, over 600 kids a year under the age of 14 die from fires. It is their third most common injury causing death, and is definitely the traumatic related injury that leads to the greatest hospital length of stay. This is a little guy that I took care of in Minneapolis. I used to take care of all ages there. And that little thing you see on top of his head is actually a dressing for his donor site. So children have big heads, small bodies. Their heads work beautifully as a donor site. No, they don't. We don't transfer the hair to the area. We actually are taking skin so thin it's above the hair gland level. So once we've taken that skin, their hair grows back in. So this site actually heals up quicker and causes less pain. About 300 people a year die from burn-related injuries, with a huge percentage of those, somewhere between 75 and 80%, who die at the scene of the accident. Over the last 40 years plus, we've been able to see a 50% decline in burn-related deaths. We used to be able to save a 50% burn about 50% of the time. We now can save somebody who is greater than 90% burn more than 50% of the time. And case in point, this is a family. The young lady in the wheelchair was 36 years old when her car carrying her mom, dad, and her husband was hit by an asphalt truck. It pushed them up onto the median. Their gas tank caught on fire, and they were immediately in a fireball that rode 150 feet down that median before they could get out. Her dad died at the scene. Her mom, who is standing to her right, was 60% burned, and you can see she looks fantastic. And Jamie was 95% burned. We're very grateful that she survived. She's an amazing survivor. This is her, and you can see she has only one arm, and of that arm, doesn't even have a hand to speak of, no fingers. She has a thumb. She threw out the first pitch at a Colorado Rockies game, which was pretty exciting for all of us. So that's pretty cool. So I always tell my patients, if they want to do something after they recovered from the injury, they can do it. They have to want to do it. Can they even start something new? Absolutely. Jamie has been able to find a way to go back to golfing. She has gone skiing. She has rode a horse. She's thrown and she threw it. She did a really great job. I'll have to add that video. She threw the pitch herself, which was pretty cool. So you can see the survival rate nationally for burns patients. Our survival rate is even a little bit better. So only about 2, and it's actually lower than that now, about 2.4% of our patients actually die from their injury. So we have a fairly good and significant survival rate. When these patients, when you initially see these patients, it's important to follow your trauma protocols. Always treat them as a trauma, unless you know exactly what happened. Treat them like every other trauma patient, meaning if they need a C-collar, they need a C-collar, use log roll precautions, all those sort of things. They can have a little bit, they can more easily and sooner start to develop problems with their airway. You also need to get them out of that burning process, which could mean taking off gasoline-soaked clothing, etc. You want to keep them warm. They'll become hypothermic very, very quickly, and they can sometimes be a real bugger to get an IV in. This patient was a young girl who was burned in Cambodia. Cambodia does not have a burn center. Her family contacted the U.S. Embassy, which contacted us because she had been living in the state of Colorado. And between the U.S. Embassy and our dock line, they got hers transferred safely. It took about 29 hours to get her transferred from Cambodia to us, but she got to us in beautiful condition. And so I give all those folks all the credit in the world for doing a great job. When you take care of these patients, make sure that you protect yourself. We all want to go in and help, but if you're going to smother the flames, make sure that you're not going to burn yourself. I grafted a lady last week who significantly burned to her hand and forearm because she tried to put another gentleman out. He actually sustained no burns, but she ended up with deep 3rd-degree burns. So protect yourself. When you see him put everybody on 100% O2, it will help anybody and everybody. You can assume that there's a carbon monoxide exposure, unless they were in an outdoor environment, then it's very unlikely. You can see the half-life of carbon monoxide on room air is significantly longer than if you put them on 100% O2. Primarily, the treatment for carbon monoxide is to put them on 100% O2 and do a fluid resuscitation. There has been no evidence-based outcomes for patients that end up going to a hyperbaric chamber for that. I know we try to do it because we can't think of anything else to do, but it hasn't really shown any significant improvements. If these guys need to be intubated, obviously intubate them. We will never tell you differently. I respect you and I know that you're there in assessing the patient, but if you can, before you intubate them, please get as much information as you can. We do get people extubated as quickly as we can, but when they first get to us, we may not even know their name or their age or their allergies, medications, all those things. Any of those things you can give us is really, really helpful. Inhalation isn't always obvious unless they're in a situation as you can see below. This was Minneapolis apartment fire on New Year's Day with temps well below 0. Lots of people came in with significant smoke inhalation, but that, in this case, pretty easy to figure out. If they get a flash burn, they will always have singed hair, singed eyelashes. Very unlikely from a flash that they will ever have any significant smoke inhalation injury. If they do have smoke inhalation injury, it will be because they were in an enclosed space. They breathed in the fumes for a period of time. They will have stridor. They will be hoarse and raspy and often kind of gasping for breath. They may be coughing up significant carbonaceous sputum. This is kind of what I talked about is the main reason that people die at the scene of the accident. With smoke inhalation all by itself, nothing else, it increases mortality by more than 20%. That number you saw before was our mortality rate goes up a lot for these patients. When they first get to me, and the only real true way to diagnose smoke inhalation is by doing a bronchoscopy. This is our smoke inhalation protocol. Everybody gets put on 100% O2 humidified. They undergo a fluid resuscitation if it's a significant smoke inhalation requiring intubation. We start them immediately on these nebulizer treatments. albuterol, heparin, and mucomist. And we do those every 4 hours for the first 48 hours. We will also bronch them as soon as they get in to look and see how significant that injury is. You cannot tell from an x-ray or any other way really how bad the smoke inhalation is without actually taking a direct look. That machine you see there is called a MetaNeb machine. It doesn't require, it's kind of misleading. You do not have to give a nebulizer to use the machine. The machine works a lot like the percussive vest that we are maybe more familiar with, but it causes that percussion within an ET tube or within a mask. And so it helps to get those secretions up and out of those airways. People smoking on HOMO2 are often going to look a lot more wicked than actually the injury is. It generally is a nasal cannula that starts on fire. It burns up quickly like a firecracker wick, and it puts off a lot of black smoke, but it's on the outside. You will see some black soot in their nares, but I've almost never, I don't think I've ever seen a smoke inhalation injury from it. Yes, they have a burn to their face. Yes, they have soot in their nose, but there is no airway involvement beyond that. And actually, once you clean their little faces up, the burns actually don't look nearly as bad as what you see in this picture. I cannot even remember the last time I had to graft somebody who had been smoking on HOMO2. So how do we manage them? And often this can be done at the outside hospital as long as they are comfortable with it. We keep these patients on their home meds as much as possible to keep them stable. They often have a lot of comorbidities. We do facial wound care 3 times a day, which involves gentle soap 3 times a day. I generally let a washcloth soak on that area, then gently clean it, and then apply bacitracin or a really good moisturizing thing like Aquaphor to keep the wounds moist. And they can apply that as needed. I will give them Afrin for about 3 days to get the swelling out of the nares. It gets a consult if there's any eye involvement. Once they have titrated down to their HOMO2 level, they're on their home meds, they're eating well, they're safe to go home, or they have someone they can go home with, that's when we discharge them. Most of the time, as I stated, they do not need to be intubated. And as we all know, patients that are already on HOMO2, intubating them can cause a significant change in their quality of life if they go on to require tracheostomy tube. Cyanide toxicity is difficult. There's even questions on whether or not it actually really happens. The symptoms are hard to pick up on because they mimic a lot of other things. The patient's anxious because of the injury, not because of cyanide. They may have carbon monoxide exposure. Do they need to be resuscitated, and that's why they're tachycardic? Do they have a missed injury from trauma that we just haven't picked up on? To test for cyanide, there's no simple, rapid, or reliable test. It's a send out. It takes 2 to 3 days to come back. And frankly, if they did have cyanide toxicity, they would be dead by then. There are 2 cyanide kits. This is the older kit, very seldom used any longer. It was called the Cyanide Antidote Kit. It had 3 parts that you had to do to treat them. Basically, force the patient's hemoglobin to form methemoglobinemia so that it would bump off the cyanide. The cyanide would then be excreted. But because of the methemoglobinemia, it also caused them to become significantly hypoxic. If they had any sort of heart disease, it obviously worsened that. They become very unstable, and several patients died from the use of this kit. This is the newer kit that many of you may be familiar with, the Cyanokit. This is high-dose vitamin B12. This was used in Europe for about 10 years before it came over to the US in 2006. What it does is the high-dose vitamin B12 binds directly with cyanide and then excretes it out through the kidney. The issue with it is it causes reddening of all the fluids in the body. So their skin turns red because of the plasma, urine is red, blister fluid is red, tears are red, everything's red. And because of that redness in their plasma, it interferes with a lot of lab tests. You can see the ones listed there. For a dialysis patient, this it doesn't turn light red, it turns the color that you see below. That color signifies to the dialysis machine that blood is passing through that membrane, and so it will automatically shut down the hemodialysis machines, and you can't override it. So it can take up to 6-7 days before you be able to dialyze that patient. And this is really what I see almost 100% of the time. Day one looks like a really dark red or really dark Zinfandel. Day 7, we're down to a Chardonnay. So it really stays in their system a lot longer than what the kit will tell you. I think it tells you 48 hours. It's more like 7 to 8 days. After the Cyanide Kit had been out, Cyanokit had been out for a while, we did a survey of all the burn center medical directors in the U.S. and wanted to see what people were doing. One center in the survey tested every single patient that came into their unit if they had suspicion of inhalation injury for cyanide. They never found one patient with an increased level of cyanide. Why do we think that is? So when the fire happens, yes, cyanide is produced, but cyanide actually burns itself, it gets burned up by the fire itself. So as soon as the fire reaches a certain temperature, the cyanide burns off as quickly as it's produced. So seldom, we feel seldom to never do patients get cyanide toxicity. So should we treat it? In this survey, most people felt it was very uncommon, if ever. There is no human data to say that it really happened. And generally, we recommend doing just doing a great fluid resuscitation. Well, generally, these patients will do just fine. Who gets resuscitation? So anybody, any adult with more than 20% total body surface area, 2nd and 3rd degree burn. Kids greater than 15%, and I would also add the elderly in that number. Patients with a significant smoke inhalation requiring intubation, and patients that have a high voltage electrical injury. Delays and over resuscitation have equally poor outcomes. So delays in resuscitation lead to hypovolemia, hypotension. That can lead to injury to the heart, the kidneys, etc. It also causes the blood vessels going to the skin to constrict, to preserve that volume for the larger organs, and that leads to conversion of the burn wound from 2nd to 3rd degree. Over resuscitation causes harm in another way. Doing an over resuscitation for a patient can lead to a lot of tissue edema and swelling. The tissue edema and swelling then constricts those same vessels, leading up conversion burns from 2nd to 3rd degree. In addition, it can lead to compartment syndromes in their hands, arms, legs, and their abdomen, so which increases morbidity and mortality significantly. So you want to make sure that you're resuscitating when you need to, and I'll give you some key tips on how to do it really successfully. IVs can become a bugger with these patients. It is always okay to put an IV in through burned skin. If you look at that previous patient, Jamie, who was 95% burned, I didn't have any not burned skin to use. So all of our IVs and central lines were through burned skin. We know how to dress them, it works well. You do have to sometimes work on how to keep that IV in, and it may mean you have to drop a couple stitches in to hold that IV stable while the patient is transporting them. Interosseous are just fine. These are what we ask our pre-hospital people to start the resuscitation fluid rates at. So adults, and that means anybody greater than 14, 500 cc's an hour. Kids 6 to 14, 250, and kids less than 6, 125 cc per hour. This is what we recommend for pre-hospital providers, as well as once they get to the emergency department, until you know, or we've discussed it and we decide that we should start the rate at a different rate. But this is what you can start them at and leave them at until they get to us unless told otherwise. Keep in mind, kids under the age of 5, you should probably consider starting D5-LR. Their glycogen stores go away very quickly, so they need to have an additional maintenance rate with D5-LR to keep their glycogen stores up. We ask people to really avoid doing fluid boluses. Do the patients sometimes get hypotensive? Yes. We will still recommend that you stay with the resuscitation protocol. Try to avoid fluid boluses, and you may need to start them on pressors. Those inflammatory mediators that are sent out by the burn can cause some cardiac suppression, which may be another reason why they're having hypotension. Anybody that needs a resuscitation needs a Foley. And that is so that you can monitor how well that patient is doing with their resuscitation. You can see that it doesn't require a lot of urine output. So for most adults, it's pretty much 35 to 50 cc's per hour. Kids, you're going to want 1 cc per kilo per hour, and infants 2. Most of these burn patients that you see are going to be completely alert and oriented unless there is some sort of associated trauma, some carbon monoxide poisoning, substance abuse, or something else has happened. We do see, I probably see about 6 patients a year that get burned because of their seizures, or maybe even more. And so they may be acting, if they're not alert and oriented, it's not because of the burn, it's because of something else. So you want to look at them, identify any deformities, any serious associated injuries. Always follow your trauma protocols. This patient very nicely gave me her video to show us how our burn patients should be looking when you see them. From an environment standpoint, you want to stop the burn, wear protective clothing, remove jewelry and stuff again. Don't peel off anything adherent, just cut around it. Log roll the patient to get all that stuff out from underneath of them and look for associated injuries, and then wrap them up quickly and keep them warm. They'll get hypothermic even faster than trauma patients. There are a lot of different types of ways that you'll see that you're supposed to measure the percent of burn. There is the London Browder chart, which you can see on the screen, which changes depending on the age of the patient, so it can become kind of complicated. There's also the rule of 9s, which once again changes depending on the age of the child. I am a big fan of keeping things simple. So what I like to use, and I find far more effective and much more accurate, is the patient's hand. So their fingers in the palm of their hand of that patient is 1% burn. You can make a template of that and quickly march it off. It will be a million times more accurate than what these charts are. If you look at these charts, it is pretty easy to see that that's a fairly fit gentleman on those pictures. Well, first of all, girls don't have their body parts don't look like that, so that's not accounting for breasts or hips. And when I worked in Minneapolis, which, as you know, is pretty close to Wisconsin, there's lots of beer and cheese eaters up there, and so lots of beer bellies. Beer bellies will throw off your calculation as well. First degree burns are like a sunburn, only damages the very outermost layer of the epidermis. It usually heals in a few days, generally does not require admission, does not need narcotics. They do well on scheduled ibuprofen and Tylenol, and we don't include the percent of 1% in our total body surface area calculation. Second degree, these are burns that have destroyed the epidermis. They're going to be more swollen, red, they may blister, the blisters may have peeled off. These will generally heal within 2 weeks and don't go all the way through to the dermis, through the dermis into the subcutaneous tissue. And you can see a couple examples of this on the screen. That child pulled a hot liquid down, he ducked, you can see that the hot liquid went down his back towards his butt. That's kind of a first degree injury, but the area from mid back up are all second degree burns. Third degree burns affect all the layers of the skin. The patient generally does not feel pain in those areas of third degree burn. They will feel touch, but they don't feel pain. So they can feel touch and pressure, but not pain. And if you push down on the skin, it won't blanch and then pink up right away. It will also feel different. So if you run your finger across the skin, you will feel a difference in texture when you get to these areas. Both of these examples are third degree burns. Both look very different. The one that is intubated, that's a pretty obvious one to pick up on. The gentleman next to it was a gentleman in South Dakota working on a carburetor. Pretty much all of that is third degree burn as well, but looks much different. Escharotomies, especially if they're coming from a distance, may be necessary for a circumferential third degree burn. Circumferential second degree burns will not form a compartment unless they get over resuscitated. And so this is one of my residents doing, and we do those medially and laterally. Once again, I can talk pretty much anybody through when, where, and how to do this procedure. And I believe this will show her doing it. And so when you do this, you'll go through and we use cautery. That tissue is all third degree. I'm going to remove all that tissue in the operating room, so there's no need to use a scalpel or something that won't burn the sides of the skin. So you want to go down until you just reach the base of the dermis, and the skin will literally pop open, and you feel with your finger. So you can see closer to the ankle, that tissue that hasn't popped open, she hasn't quite gotten through. If you get into a significant bleeding, and basically she's just dabbing at skin bleeders, and there I'm indicating to her that she hasn't quite gotten through deep enough, then you've gone too deep. So if you get into the subacute tissues and get into a lot of bleeding, you're too deep. So back off a little bit. And it's really doesn't take a lot to get into the right level. Oops. If you're going to transfer your patient within 24 hours, you don't need to do any fancy debridement or dressing. Keep them covered with clean, dry sheets and blankets. Thermal insulation blankets in route are awesome, as well as the ones that little silver hats. Avoid any wet or gel dressing. This will contribute to hypothermia pretty quickly. When the patient gets to us, and you are always welcome if you are the provider bringing the patient in, we often have helicopter crews or even ambulance crews hang around and kind of see what we do. This is what the room looks like that we do the wound care in. It has a raised bed on it. We place the patient on it. It then has some hoses that are antibacterial with a nozzle that makes our water sterile that we will then, and the room temperature is easily brought up to over 100 degrees. So we crank up the temp, we monitor the water temperature, and we clean those wounds on those tables. Once they're clean, then, and you can see this is I call them a tub team or a wound care team. They put on sterile garb and they will put the dressings on as sterilely as they can. And by doing this, we've been able to decrease burn wound infection rates by over 50%. If the transfer is going to be delayed, contact us. We're happy to talk with you and kind of figure out how to do that. We all know what the weather can get bad, and it's not always possible for people to move. You will want to, for the most part, use some sort of gentle soap, clean the wound. Any blister that forms that's greater than a couple centimeters, you're going to want to unroof those completely. It's chock full of inflammatory mediators. We dress these wounds. I would squirt a whole bunch of bacitracin into some sort of non-stick dressing, be it adaptic or zero form, scrub the bacitracin into that dressing, and then lay it over the burn wound. Don't try to rub Basi over that burn wound. That hurts more and it's not necessary, but put it into the dressing, the non-stick dressing, lay it over, then wrap the wound with some sort of gauze and something to hold the dressing in place. Typically on the extremities, I will use ACE wraps. On the trunk, you can take a clean t-shirt and cut it down and actually use the t-shirt fabric to hold things in place by stapling the t-shirt fabric to itself. Works pretty slick, actually. We do not use Silvadene for the most part, and we definitely don't use it front line. Silvadene blocks wound healing. It affects the keratinocytes and the fibroblasts, which the wound needs to heal. And so it actually slows down wound healing. It's interesting to me, whenever I read a study that's trying to talk me into using a different sort of topical on my burn wounds, they will always compare themselves to Silvadene. Why do they do that? Because Silvadene, and I found a study that showed this, works worse than nothing. So Silvadene outcomes are worse than putting lotion or just water on the wound. So if you want to make yourself look good and make your study, use Silvadene. That's my little tip of the day. Electrical injuries, these are often a lot more serious than what they appear. This is a case in point. I'm sure some of you guys can figure out what is causing that ferning pattern that you see on this young man's chest. This gentleman was out camping with his girlfriend. Both kids were 18. They just graduated from high school, and it was early summer, and they were enjoying the weather. They were not up on the tip of a mountain. They were up in the mountains, but were in a low-lying area. Nonetheless, this young man who had headphones around his neck, which is where that mark on his neck came from, stepped out of the tent and was struck by lightning. He fell face down. His girlfriend didn't know what had happened, walked out, could smell the smell of sulfur, and found him in asystole and unconscious. She flipped him over, had just learned CPR. She wanted to go to nursing school and had just learned CPR. She started CPR on him and was able to get him back completely into a normal sinus rhythm, neurologically intact. Lightning strike injuries are, all bets are off. So if the electricity arcs, they will often have much more cutaneous damage because the arc can cause a temp, whether it's electricity or lightning, of over 500 degrees. But I've seen several lightning strike patients that come in and this is all they've got as far as a very small injury, but they've gone into complete cardiac arrest, resets the brain cells, so it's like they've had a stroke, so they don't breathe on their own, and so it's a very significant injury. So all these folks get put on a resuscitation protocol to make sure that the damage underneath the skin, as the electricity goes through the skin and the tissues, it conducts differently. And bones work like a resistor. They heat up and cause damage to the muscle tissue, which leads to the formation of rhabdomyolysis. That's our young man, by the way, the next day. Nancy and I, we had a request to do a talk on lightning strikes and electrical injuries to basically the National Weather Service group. And this young man agreed to come in and speak and tell what his side, which was really, it was really interesting. It was fun to hear him talk about how things were on his side. His worst thing of the entire injury was the Foley catheter. I apologized to him at the time, but I basically said, you died, so you get a Foley catheter and I get to watch and see how you do overnight. So he then agreed that that was probably okay. But that was his worst experience of the entire injury. Other than that, he thought everything went really, really well. So they get a resuscitation, they get a Foley. You will check serial CKs every 6 hours. You will monitor the urine to make sure it's clear and yellow. And you want to maintain a higher urine output, generally 1 to 2 cc's per kilo per hour. Kids, 2 cc's per kilo per hour. Chemical injuries. I don't know how it was in North Dakota, but here in Colorado with the shutdown and everybody at home and nobody being able to go into work, everybody thought it was a really grand idea to do a lot of do-it-yourself projects that they weren't quite qualified to do. This is what your knees look like if you kneel into cement for an extended period of time without protecting them. This guy was doing a home fix-it-up project, working with cement. What happens with these are, it's an alkalinic injury. The cement is cold. You don't even realize that your skin is burning until you stand up and start moving around and the tissues warm up again. By then it's way too late. So he showered immediately. You want to irrigate these for at least 30 to 45 minutes to neutralize that chemical, regardless of what the chemical is. And then dress them like you would other burns. A lot of these cement injuries end up coming in and getting grafting, which this guy did as well. Chemical injuries that affect the eye can take much longer to neutralize, and I have seen cases where I've had to neutralize eye injuries for up to 24 hours to get the pH back to normal. Generally use a Morgan lens. Lactated ringers burn less than normal saline, and just keep irrigating until you get the pH strip normalizes. This is a special type of injury, hydrofluoric acid. This is actually a homie, so he's from Jamestown, North Dakota. He was working, owns a Harley shop, was working with a part stripper. He did have the appropriate gloves on. However, unbeknownst to him, the glove had just a small hole in it. He got a drop of hydrofluoric acid on his thumb. You can see the initial injury is just white, like a 3rd-degree burn. As it starts to turn that lovely shade of green. And by the time he got to me in the bottom picture, I had to put him on a calcium infusion through an art line to get that injury to resolve. So hydrofluoric acid, you flush them just like we talked about, but you then have to apply some sort of topical calcium in order to neutralize the fluoride ion. The most effective way is to take an amp of calcium gluconate, equal amount of KY jelly, mix it together in a little specimen cup, and keep reapplying it every 15 minutes until the injury is completely neutralized. If they start to develop that green injury, the injury has gone internally, and you're probably going to have to do an intraarterial infusion. All these patients require cardiac monitoring because the fluoride ion chelates out a bunch of calcium and magnesium in the system, which can then lead to cardiac instability. This is the only chemical injury that I'm aware of that turns the skin this shade of green. I developed a protocol with our poison control service when I was up in Minnesota, brought it with me to Colorado. Colorado's like, oh, we've never seen that. And lo and behold, this guy showed up. So this gentleman was working with a more dilute hydrofluoric acid solution. It's found, unfortunately, in a lot of floor strippers, window etching, a lot of different industrial types of situations. It's even used, I took care of a guy from Western North Dakota that was used to clean the barrels of oil out. So it's in a lot of stuff. What's important is to, from a pre-hospital standpoint, is bring the can or label from whatever it is so we can figure out what the percentage of hydrofluoric acid is. This guy, once again, didn't come to us right away. You can see the green tint. Immediately upon starting his calcium infusion through his art line, his skin normalized in color. You can see that he's gone back. That white wrinkly you see, that's from the hydrofluoric acid. That's my happy camper going home the next day. Abuse happens to all ages. We see it in kids, but you also have to suspect it in adults. You can see that with kids, we see a lot of it affecting single parent families. In this case, it was a young child who was home with her mom's boyfriend. Mom was at work. Mom comes home, goes to tuck the child in and sees that the skin is starting to peel off. The story the boyfriend then tells mom is, well, she stood in the shower on her own in scalding water and screamed and yelled till I took her out and saved her from further injury. Well, you can see by looking at this, number one, that's not from a shower. That's from somebody forcing a child into a bathtub. These patients don't do very well. They don't do as well as patients without abuse. We see the same thing with patients that try to burn themselves up in an act of suicide. They have a much higher rate of needing skin grafting. More of them require ICU admissions for a smaller amount of burn. They often require a feeding tube because they will not eat. This is a young man who climbed into a bathtub. Story was he's autistic. He doesn't talk or scream or feel pain. So he climbed into the tub with his diaper on and started the scalding water. Well, autistic kids feel pain, and he was obviously talking to me when he came in. And if he had been in his diaper in the tub for any period of time, his little bottom would have been burned worse than his legs. And that's my little dude as he was healing. Kids are fun. Kids don't have all the preconceived ideas that us adults do. So their pain is easier to control. They do their therapy for just little rewards. This guy, give him a glass of milk, he'll go anywhere for you. So very nice. And that's when he got older and had been placed with a family. You can see that the mortality rate for abuse is almost double that of non-abused patients. What else do we take care of? Well, we do a lot of red rashes, lots and lots and lots of red rashes. I think when I was in residency, they're pretty much the red rashes were always Steven Johnson or TENS, and or they had other things like pemphigus and other stuff that we took care of. Now there seems like the red rashes have turned into lots of stuff. The kid up top is from Fargo. He had toxic shock, it's called the skin syndrome. Lady below does have toxic epidermal necrolysis. We do a lot of significant road rash. As you can see at the top, we take care of and reconstruct patients after going through debridements for necrotizing fasciitis. And that injury you see on the side, the purple injury, that's an internal degloving injury. It has a big name called Morale Lavallée. But basically the skin and fat separates from the fascia and muscle below. The skin then loses its blood supply and can completely necrose off. And so we get consulted to try to prevent that and to take care of the skin if they do lose a lot. Obviously, you learned all about frostbite, so we'll move on. And I'm going to end with a case presentation. This is a man who lets me use his case, and it's a good example of both polytrauma as well as burn and kind of the patients that we see. Denver has a very, very, very large homeless population. And this was one of the unfortunate homeless guys. He lived in front of that liquor store, right in front of where that car is parked. That's where he slept every night. During the day, he helped out the liquor store owner and some of the other store owners around that area for food and for things like haircuts. And he was overall pretty well liked by all of the people in the neighborhood. One night as he slept, you can see that an ambulance was called out. This was the 7th of November at around 10:30 at night with reports of, actually initial report was a garbage can on fire. It actually was a man on fire. They got there, they recognized this gentleman, had taken care of him before. He was lying on the ground in a fetal position, was alert to himself, but confused and fairly combative. And this is the security camera of this gentleman being attacked. He had multiple types of wounds, including the burns. He had multiple long stab wounds to the areas that you can see. The guy tried very hard to kill this gentleman, and we still don't know who he was or why. And you can see where his burns were. The Denver Health paramedics did a scoop and run, took him immediately over to Denver Health, which was close by. His heart rate was increasing. He was started mildly tachycardic and became more. They had started him on O2 by nasal cannula, had gotten a 16 gauge IV in, were giving him fluids, and gave him a little bit of Versed for the agitation. They had placed a petroleum gauze dressing over the sucking chest wound on his left chest wall. At Denver Health, they did a very rapid full trauma workup. He was extremely unstable. You can see what his head CT looks like with a depressed skull fracture, significant subdural and subarachnoid blood underlying that injury. He was taken emergently to the operating room for an exploratory laparotomy and thoracotomy, where he underwent a partial lung resection as well as a splenectomy. Those are the blood products that he got. Following his laparotomy, he was transferred over to our burn center, where we then consulted trauma, opto, and neurosurgery and started him on our burn resuscitation protocol. At this point, he had an open abdomen after a splenectomy. He had a chest tube, which you can see is in a very odd place, but that was the only place they could put it that wasn't through very badly burned skin. He was intubated. He had a central and art line placed. He was on Levophed and vasopressin, which actually weaned off very quickly after we started resuscitating him, with these very large open stab wounds and about a 15.5% very deep 3rd degree burns to his body. He underwent a left upper extremity escharotomy due to the tightness of that eschar. He went through his resuscitation, was quickly weaned off pressors, and underwent a bronchoscopy to rule out quickly any sort of inhalation injury. And as with almost 100% of these, if this happens outside, there was no evidence of smoke inhalation. The next day, he went to the operating room with our trauma service. They did an abdominal washout and closure. He was very stable on the vent at this point, and his chest tubes were putting out 200 to 400 cc's per day. My friend had a very significant alcohol history, which is why the paramedics knew him. He went through a horrendous alcohol withdrawal, which delayed us from being able to get him off the vent for some time. The C-spines were cleared by neurosurgery on the 14th, which is 1 week after the injury happened. His chest tube came out a little over a week later. He underwent a bronchoscopy on the 16th, and due to the extended period of time on the vent, had developed a pneumonia and was treated for that. On the 17th, and I didn't know it at the time, but this was very telltale of my friend's personality. He pulled his ET tube out. He tried to very proudly present it to his nursing staff in the middle of the night, and his nursing staff very quickly put that tube right back in where it belonged. He had a total of 8 trips that he went with us to the operating room. You saw the size of that big wound, which opened directly into the lung cavity, which made it difficult. We had to get those tissues to all seal down before we could actually get a graft to take over it. So it took a few times of us going back and forth. A lot of it was putting on a wound vac and taking it off as well. He got formally extubated on hospital day 13, was downgraded on hospital day 17 to step-down status. And on hospital day number 25, during our weekly multidisciplinary rounds, was found to be appropriate for discharge within the next 2 weeks. But guess what? Our friend Matt, he's homeless. He doesn't have a home to go to. He is cognitively impaired from his traumatic brain injury, and we were not able at this point to find any power of attorney or family for him that we could talk to help set up discharge arrangements for them. We, by the way, even though we take care of a large number of homeless people, we don't discharge homeless people to the street. Our homeless population is all discharged to respite beds or to a different living situation. This has got my guy, Matt. He's cute as a bug's ear. He underwent pretty much his physical and occupational therapy and rehab while he was in the hospital with us for almost 9 months while we worked on getting disability and getting him placed in a home. He took great care of his grafts. He put lotion on it several times a day, refused to wear a shirt, which is why he is not wearing a shirt in the picture. And as I stated with his personality, he would occasionally go off on what we call jaunts. And this would be him wandering off the unit and ending up somewhere. Sometimes it was in the ambulance bay. Sometimes it was on another floor. Sometimes it was all the way out to a street we call Colfax, which is not one of the nicer streets in town, where he would find little treasures and bring them back with himself. What Matt knew, which was good, was my name is Matt, and I live in the burn unit on the 3rd floor. And by knowing that, they could always get him back to the right place. So he underwent, you can see showing you there, he has a contracture of his posterior axillary line. We fix those on a regular basis. We have a pretty aggressive burn reconstructive service as well. So I did a Z-plasty on his underarm. And what was even more, and we see this a lot, he reconnected with his family. He found his sisters found him. They became his guardian and helped us with placement for him. That's my dude after he got his contracture release. By the way, I tried to buy him a shirt to maybe make him wear a shirt and think that was a lovely thing to do. He loved Stephen King Dark Tower series. So I bought him the final Dark Tower book and I got him a matching t-shirt, and he very nicely said, "Thank you, Dr. Wagner." And it stayed in a nice little package on beside his bed. So I tried, but eventually, once he left the hospital, as you can see here, my boy started wearing a shirt. And this is Matt coming back to see us. You can see he's now gained weight. He looks healthy. His color looks good. His contracture is still completely resolved. This is about a year after discharge. He remains sober and clean, living in his halfway house, and has a great relationship with his family. I didn't use him because he's the only guy like this. We actually get a fair number of our patients who end up becoming sober and leading a sober lifestyle after their injury. We have a really awesome support group for all of our patients after they leave the hospital. And for you folks up in Dickinson, this is done, and we were doing this before COVID, but it's done through Zoom or Skype. And so any survivor anywhere that you know can become part of our twice a month meetings. And people all over the place tune into those meetings and are able to find a lot of help. In addition, our survivors, we haven't been able to do this now because of COVID for a while, but there is a yearly conference, which is really amazing, called World Burn. And we usually pay to have anywhere between 2 and 4 of our patients that get a free trip to that conference, along with some of our workers in the unit, part of our team. It's a pretty moving conference, and I get teared up even just reading some of the statements that they say once they're there and looking around. And so it's a pretty cool thing, and certainly look into it if you guys have any interest. So I stated we do a lot of laser and also burn reconstruction. There's my friend Jamie, who you saw pitch the first pitch out to the Rockies. Her and we're both from up north, but we have become huge Rockies fans. And so that was a really cool moment for the two of us. This is our team. You see multiple different members. The guy kneeling is one of the guys who's worked in the unit longer than almost anybody. And he is one of our wound care techs. That you can see the patient and her husband, a couple of our nurses, our burn fellow, the guy with the funky mustache who's a packer is in the back. That's Steve. He's great. He's an occupational therapist. So our patients become part of our family. Our patients will come from multiple states away to come back and visit and to see the different providers and team that have taken care of them, which is always very rewarding to us. This is one of my little guys that I did a Z-plasty on. You can see there it's very evident within a month of doing a Z-plasty like that on his arm, you won't even be able to see that it was there. Laser is good for a lot of things. It can help flatten the skin out. It can help with the discoloration. But even more importantly, and what has really improved our patients' quality of life is the fact that it gets rid of burn itch, which can be very significant after a burn injury. It gets rid of what my patients call zingers. So it gets rid of their nerve pain as well as doing the scar remodeling. That's the number for our burn and frostbite clinic. Anyone can call it. Like I said, answered 24/7. We're happy to see anybody. Just leave your name, your number, and you'll get a call the next day to get you in to be seen at the clinic. We also are doing a lot of virtual clinic visits, and Nancy and I are working on building telehealth clinics throughout all those states that we serve so that a patient could go, for instance, to a clinic in Dickinson and do a telehealth visit there. So more to come on that, but we are pretty actively working on that right now. This is the number for our doc line. Like I said, answer 24/7. They're an amazing group of operators. I love working with them. But they will take your call and get you directly connected up to whoever it is. It could be you're looking for some other sort of service, and they will help you out or help steer you in the right direction. That's the burn and frostbite app we talked about. And this is Denver on a clear day, which I might add, over the summer with all the forest fires, we didn't have any clear days for many, many months. So this is a nice little change. That's my email. Once again, please don't hesitate to get a hold of me. You can ask questions. You can ask for whatever you want. If I can't answer, I'll get you to the person who can. And I really thank you and appreciate you listening to me today.